Hello, and welcome to this clinical insight case discussion on the diagnosis of IPF. My name is Dr. Maryl Kreider from the University of Pennsylvania. I would like to thank my esteemed panel for joining us today. There are several things to consider when evaluating a patient for suspected IPF. Things like associated autoimmune disease, occupational exposure, and family history. And this will help us distinguish among IPF from other fibrotic lung conditions. To begin, let's do a case of a 57-year-old nurse practitioner who was previously well and very fit, in fact, typically ran 3 miles a day. 3 months ago, however, she developed hives that were thought to be a reaction to shellfish and some hand and wrist stiffness and fatigue. About a month ago, she started to notice profound fatigue, severe stiffness of the hands, and progressive dyspnea on exertion, and it even noted that it was hard to make it up the steps at work. She saw a local physician and a pulmonologist, and they sent some lab work and told her that she had a positive SSA, normal rheumatoid factor, ANA, SED rate, and had some restriction on her PFTs and abnormal imaging. They recommended a bronchoscopy, which was non-diagnostic, and then referred her to a local surgeon for VATS, who told her that she had pulmonary fibrosis. She comes to you now for a second opinion. And this is her CT. Jesse, would you want to look at that for
Sure.
us?
We're looking here at the upper third of the thorax. I have to say at this stage I'm not very impressed with any significant changes. But as you go further down, you start seeing some ground glass opacification that is quite diffuse on both left and right lungs, with more predominance on the right side, right posteriorly. And of course, this becomes more prominent. There's a significant amount of ground glass opacification bilaterally. Interesting enough, there are some features that are not seen here. I don't see honeycombing. I don't see pleural abnormalities. I didn't detect significant lymphadenopathy. I didn't detect massive consolidation suggestive of a pneumonic or infectious process. The heart doesn't seem to be enlarged. So those are all important features that will help you distinguish one disease over another.
And given the history that we've heard so far in this kind of CT, what processes are you considering?
Well, I'm certainly worried about an interstitial lung disease process related to an autoimmune disorder because of the gender, the age, and the manifestations, particularly her, not only her dyspnea, but apparently her changes in her hands and the positive nature of the serologies presented.
Can you describe this as a pattern? Is this a UIP pattern? Is this an NSIP pattern?
This is not a UIP pattern. This is, again, UIP pattern, you expect to see honeycombing, you see peripheral and basilar predominance. In this case, what you're seeing is significant ground glass opacification on both sides. And thus, the pattern that you detect in other idiopathic interstitial pneumonia, such as nonspecific interstitial pneumonias, or NSIP, which you may see more frequently in rheumatologic disorders, for example.
You know, it's interesting looking at the CT scan that you can see air bronchograms in some areas as well. Not maybe a little bit of bronchiectasis, but prominent air bronchograms in these sort of fan-like ground glass pattern, which is a pattern that, while not specific, raises organizing pneumonia because it suggests it's a bronchial-eccentric process.
Yeah, I think you see that in the posterior aspect of the right lower lobe and the paravertebral area. There's a good example of that.
Right.
And here's her pulmonary function testing.
So if we look at our pulmonary mechanics, they're at the lower limits of normal. Her forced vital capacity is 79% of predicted, suggesting some mild restriction. Her FEV1 FVC ratio is normal. She had total lung volumes performed, which again showed mild restriction with a total lung capacity of 77% of predicted. Interestingly, her DLCO is very low. It's 46% of predicted, and she had an exercise step test, and she desaturated to 82% with exercise. So she has significant gas exchange abnormalities despite a fairly low, mild level of restrictive disease.
So we learned a little bit more about her when she came to visit us. She reported that she was a never smoker. She denied any exposure to hot tubs, birds, bats, barns, travel, and she had no significant past medical history to suggest exposure to radiation or other medications of concern. On exam, she was notably crackling, and she had the hand findings seen on this slide.
So the hand findings are interesting. She has, in this one photograph, evidence of thickening along the lateral sides of the fingers with some fissuring of the fingertips in a pattern that's very reminiscent of mechanics' hands. She's obviously not a mechanic, but she probably, the story I would get often is that, I wash my hands 25 times a day, so my fingers are always dry like this. But this is a pattern of dryness that really points to a mechanics hand process, which we would associate with one of the myopathic or myositis-associated lung diseases. So this is and this would be a very typical appearance for that.
You certainly worry about that even more with her muscle weakness, with the stiffness that she has, with the rapidity of symptoms. I mean, she was running 3 miles 3 months ago, and now she's short of breath, desaturates. I mean, this is moving quickly. This is scary.
And her serologies were repeated and are notable for an elevation of her SED rate. She has an elevation of her CPK and aldolase. Her ANA is elevated. Her Jo-1 is markedly increased, as is her SSA.
So this is, again, a pattern that would go along with a myopathic process, and in this case, dermatomyositis with a Jo-1 antisynthetase. And the odd thing about this population of patients is that because of her prominent muscle weakness and myopathic findings, patients like this often end up in a rheumatologist's office first, or a rheumatologist will send them to the pulmonologist because of their lung disease, because she has these prominent muscle weakness symptoms associated with an elevated CPK. But occasionally a pulmonologist might see a true myopathic myositis. Most of the time, we end up with the amyopathic versions where they have all of these findings with the exception of the muscle weakness. But she's a more typical patient that has myopathic findings that go along with dermatomyositis, along with the skin rash and a positive Jo-1, and elevated SSA, which is supportive of that.
And she brought with her her lung biopsy specimens.
Yeah, so my question is, why did she have a lung biopsy?
That's right.
We can talk about the features, which look, somewhat like organizing pneumonia, but to me, she's got a well-defined autoimmune disease that needs therapy, and I'm not sure this lung biopsy informs how I'm going to treat her.
That's right. Even the CT scan findings would support an organizing pneumonia pattern. I agree. It's the sort of thing where you really want serology back before making a decision about lung biopsies. And a person that has a very, very high pretext probability of having an autoimmune disease, specifically a myositis.
The problem here is whatever you find on the pathology, you're going to ascribe it to the connective tissue disease. And that's the issue.
Does it help you with prognosis?
I think it could. If under the microscope we found a pattern of usual interstitial pneumonia, it's probably not going to respond to immunosuppressive therapy like organized pneumonia or NSIP. But in her case, with those serologies, I'm not expecting to find that. If this was rheumatoid arthritis, I may be more likely to find a pattern of usual interstitial pneumonia under the microscope. So it may help guide prognosis, but I would not do a surgical lung biopsy in her case to try to inform prognosis.
It's interesting. We looked at the Jo-1 antisynthetase manifestations, and there is a sizable percentage of them that will have a UIP pattern, and we followed them for long periods of time, and treatment of the underlying autoimmune disease seems to arrest the disease process, which is interesting. So even if they do have a UIP pattern, their prognosis is much, much, much better.
It's driven by the process.
It's driven by the process, exactly. So having had and I agree, I would not have necessarily considered lung biopsy in this case, but having had a lung biopsy, it's interesting we don't see an important finding, and that's diffuse alveolar damage, because obviously an antisynthetase syndrome with diffuse alveolar damage is worrisome for significant deterioration before improvement. Yeah. And there's a significant mortality associated with the appearance of DAD in an antisynthetase syndrome. But I agree. I mean, given the information that we had, I'm not sure that a surgical lung biopsy would have been the test that I would have ordered at the beginning.
In a case like this without respiratory symptoms, would you consider imaging studies?
You mean CT scans?
Yeah.
Absolutely. Yeah, absolutely. I mean, I think particularly in patients with JO1 antisynthetase syndromes, that if you look, even in patients without symptoms, you'll usually find radiographic abnormalities. It's almost always part of their syndrome, and it's important to recognize it, because if they're not having symptoms right now, they're likely to have symptoms later. These are young patients, and this patient in particular, her first manifestation of disease was that she probably went from 3 miles to 2 miles, and didn't realize that was perhaps the earliest manifestation of her lung disease, was that she was a little bit more limited. So I think radiographic findings should be a uniform part of the evaluation of patients with dermatomyositis, particularly with JO1 antisynthetase.
So to follow up what happened with this late woman, she was diagnosed with the anti-JO1 antisynthetase syndrome, and she was put on prednisone at 60 milligrams a day, and they added IV pulse cyclophosphamide with a prednisone taper. She had near complete resolution of her dyspnea and lung infiltrates, and about a year later had a very nice chest x-ray response.
Yeah, I think that highlights the importance of early recognition of the disease, aggressive therapy. I think she responded because we caught her interstitial disease when it was still reversible. If this would have gone on another 6 months, she probably would have had some fibrosis and reticulation, maybe honeycomb change, that maybe we could have stabilized the disease, but certainly not reversed it.
Well, I'd like to thank my colleagues for joining me today. This is a nice case that highlights the importance of recognizing features that don't look like UIP, and then using features of the clinical case to help recognize another process that needs early and aggressive intervention. Thank you.